equal parts. When you have heterotaxy syndrome, in the von Praguian terms, we call it situs ambiguus, which may or may not be a very accurate term. And in more Andersonian terms, we call it mirror imagery. And what that means, no matter what term you use, is that organs that typically manifest right-left asymmetry, such as the heart, develop in a mirror image way. And so if you use the von Praguian terms, you would say that situs solidus and situs inversus exist in the same patient. If you use Andersonian terms, you'll see that some of the organs that are supposed to be asymmetric become mirror image. And the heart is usually affected, again, because it's an asymmetric organ, along with other asymmetric organs, such as the liver, the spleen, the intestines, and some others. When you think about isomerism or heterotaxy, patients typically fall into two subcategories, and it's good to sort of think about, particularly when you're imaging a patient, the disease in terms of these two subtypes. And the two subtypes are left isomerism or polysplenia, which is the von Prague term. The most consistent finding that Robert Anderson will tell you is that they have isomerism or mirror image of the left atrial appendages. However, by echocardiography, that can be incredibly challenging for us to recognize, and it's not particularly important with regard to what you're going to do surgically for the patient. However, it is a very consistent finding. Patients with left isomerism have bilateral left-sidedness, so it's good to think about it in those terms. Because what will happen is they will have absence of some of the right-sided structures. Right isomerism, which is also known in von Prague terms as asplenia, consistently has isomerism of the right atrial appendages, although not something we can always see by echocardiography. This used to be called Ivermark syndrome, and again, it's bilateral right-sidedness with absence of left-sided structures, and most patients you can identify as falling into one of these two categories. It's not always possible, but we try. Much information and progress has been made in figuring out the genetics of heterotaxy and isomerism. In some cases, there have been reports where there's a teratogenic exposure to maternal diabetes, but other inheritance patterns have been noted, such as autosomal recessive and dominant, as well as X-linked. And it turns out that it makes sense that genes that are involved in early right-left patterning in the embryo, how the embryo determines the right and left side of it, are implicated in this problem. And what goes along with these issues is ciliary dysfunction, because cilia are involved in the embryo identifying right-left sidedness. Single gene mutations have certainly been implicated, such as the ones listed here. And I borrowed this slide from Professor Anderson to show you that this is a lefty-1 knockout mouse, where you see what looks like bilaterally, morphologically, left atrial appendages. You can see that they are narrow, that the pectinate muscles don't go all the way out into the atria, and they look the same as each other. Whereas here you have a PITX2 knockout mouse, where you see bilateral right atrial appendages. Now you see a sort of more broad-waisted atrial appendage with pectinate muscles going all the way out into the atria, so typical, and mirror image, of course. We've been discussing heterotaxy and isomerism for well over a century now, and these were some fascinating case reports I came upon in sort of investigating this problem. And you can see that one was reported in 1891, one in 1901, congenital malformation of the heart with abnormalities of abdominal viscera, absence of the spleen, absence of the hepatic section of the inferior vena cava. And these are just fascinating. Look how long these papers are to talk about one case report. And I also draw your attention to a heroine of pediatric cardiology, Maud Abbott, who wrote the Atlas of Congenital Cardiac Disease in the 1930s. And this is a beautiful figure from that text that she wrote, which shows a patient with heterotaxy. You see bilateral superior vena cava. You see the heart is pointing to the right, dextrocardia. You can see the stomach is on the right, the liver is on the left. And there is transposition of the great arteries. The pulmonary arteries here, the aorta is here. So very early on, this disorder has been recognized. There are many cardiac anomalies that go along with heterotaxy and isomerism, and it is quite a challenge for us from an echocardiographic standpoint, and thus it's very important to take a systematic approach. There can be segmental abnormalities. Those are the abnormalities of the atria, the ventricular looping, and the relationship of the great arteries. The isomerism of atrial appendages, which we mentioned earlier. There are very frequently systemic and pulmonary venous anomalies seen in heterotaxy. There's atrioventricular alignment abnormalities, ventricular arterial alignment abnormalities. Often there is outflow tract obstruction. There can be abnormalities of arch-sidedness as well. So a whole slew from sort of the beginning of the heart to the end can go wrong in this disorder. There are also often non-cardiac abnormalities. There are abnormalities of the broncho-arterial relationships based on whether the lungs are mirror image or not. There can be splenic abnormalities. Absence of the spleen, polysplenia are common. About a third to sometimes more than that, patients will have malrotation of the gut, which can lead to consequences such as volvulus, and as well as midline liver. Biliary atresia is a phenomenon that's seen in 10% of the polysplenia left isomerism patients only, but when you see biliary atresia in association with complex congenital heart disease, that indicates a very poor prognosis. And then there can be a whole slew of midline defects. So at the extremes, you have the mirror image, and in the midline, you can have deficits. You can have absence of the corpus callosum or cerebellar agenesis. You can have meningomyelocele. You can have cleft lip, cleft palate, or choanal atresia. There can be TE fistulae, gastroschisis, omphalocele, horseshoe kidney, and horseshoe adrenal glands. When we talk about broncho-arterial relations, in situs solidus, you see an eparterial bronchus on the right. The bronchus runs behind the right pulmonary artery, and you have a hyparterial bronchus on the left. The bronchus runs under the left pulmonary artery. In situs inversus, or mirror image, you see the exact opposite of that, or the mirror image of that. And when you have isomerism, if you have right isomerism, you'll have bilateral eparterial bronchi. And if you have left isomerism, you'll have bilateral hyparterial bronchi. And this is an X-ray, a babygram, so to speak, which really sort of brings the whole thing to its forefront. Here you see a babygram where you see that the heart is pointing to the right, so dextrocardia. You see a midline liver. You see a ground glass haziness to the lungs, which indicates obstructed total anomalous pulmonary venous connection, as well as malrotation. You can see that the small intestines are all collected over here on the right side of the baby, and the large intestine over on the left. So this really sort of shows you all of the various issues that can happen in patients who have heterotaxy or isomerism. And with regard to the echocardiographic approach, it really is sort of one of the most challenging diagnoses we make. And so it's very important to get all of the details right. You need to take a systematic approach, whichever approach you choose, just make it systematic for each patient. I think that it is very important to start in the subxiphoid view, and I'll show you some examples of how that can tell almost the entire story. And then you can describe the segmental anatomy, the situs. In heterotaxy, we for the first letter, we use A for ambiguous, and you can put in parentheses whether it's mostly situs solidus or mostly situs inversus. Then ventricular looping, and then the relationship of the great vessels to each other. And then we describe each anatomic abnormality from the systemic veins to the great arteries on the arch, obviously paying attention to the most pertinent of those details. And why do we need to know all these details? Well, it turns out that most children with heterotaxy undergo single ventricle reconstruction, not all, but most. And so there are frequently systemic and pulmonary vein abnormalities as well as arch-sidedness abnormalities. And so these vessels are not where they should be. And this can affect where you place an aortopulmonary shunt. It can affect whether you have to do a right bidirectional glen or a left bidirectional glen or bilateral bidirectional glens if you have bilateral superior vena cava, as well as Fontan procedure and where the baffle placement will be. So we'll just start by talking about some common findings to both subtypes. It's not consistent. None of these are consistent in every patient, but they're just frequently seen. And these are frequently seen in left isomerism as well as right isomerism. And that includes dextrocardia, which occurs in about 1/4 to 1/3 of patients with heterotaxy. Systemic venous anomalies are seen very frequently in both disorders. Pulmonary venous abnormalities are quite common. It is very common to see an atrioventricular septal defect in left or right isomerism, as well as right aortic arch, again, about 1/4 to 1/3 of patients. These are suprasternal views indicating some of these systemic venous abnormalities that we see. Here you see a right superior vena cava and a left superior vena cava, aorta and pulmonary artery here. And if you have left isomerism, because the coronary sinus is a left atrial structure, the left superior vena cava will go to a coronary sinus. Whereas if you have right isomerism, those patients have absence of the coronary sinus because the coronary sinus is a left atrial structure. And so the left superior vena cava will connect directly to the left atrium, most commonly. Some patients have more of a situs inversus picture, and so they will have the mirror image of normal. Their innominate vein, instead of going to a right superior vena cava, will connect to a left superior vena cava back to the heart. And that can occur in either subtype, and this is known as absence of the right superior vena cava. As I noted, right aortic arch is quite common, and because, again, this is heterotaxy syndrome, the most common type of right aortic arch we see is with mirror image branching. As you see here, you can see the carotid and the subclavian coming off towards the left in this patient, and this patient also happens to have a left superior vena cava. So mirror image branching is the most common. So let's just go over left isomerism or polysplenia. Again, just as a reminder, just think of it as bilateral left side, bilateral left atrial appendages, as we talked about. Sometimes you'll see absence of the sinus node because the sinus node is a right atrial structure. Because the pulmonary veins are left-sided structures, you might have ipsilateral veins, which is when the left pulmonary veins enter the left atrium and the right pulmonary veins enter the right atrium. And because the inferior vena cava is a right-sided structure, the segment from the hepatic segment may be absent. And the way the blood gets from the lower half of the body is by an azygos pathway to one of the superior vena cava. So we call that azygos continuation. Atrioventricular septal defect is common, as well as ventriculo-arterial abnormalities, such as double outlet right ventricle or transposition. And it is common for patients to have pulmonary outflow tract obstruction. However, in left isomerism, the patients can have aortic outflow tract obstruction as well. They'll often have bilateral bilobed lungs with hyperarterial bronchi, as I showed you in that earlier slide. And they'll often have multiple small spleens, the so-called polysplenia, but it is not a very consistent finding, and that's why some people have issue with that terminology. And as I mentioned in earlier slide, biliary atresia occurs in about 10% of patients. And another feature that is particular to left isomerism is when the patients have congenital complete heart block. Again, in combination with complex congenital heart disease, that can mean a very poor prognosis. So just to sort of give you a sense of what I mean by normal atria and bilateral left atria, here you see what we commonly see in the normal heart. You have a superior vena cava and an inferior vena cava coming into the right atrium. You have the pulmonary veins coming into the left atrium. And when you have bilateral left atria, you'll now have absence of the hepatic portion of the inferior vena cava. And so the blood from the lower half of the body has to make its way through an azygos to one of the superior vena cava. You will frequently have bilateral superior vena cava, and you will have ipsilateral pulmonary veins. And because it's bilateral left atria, you will have the left superior vena cava, which is entering into the coronary sinus, and the hepatic veins drain directly into the right-sided left atrium. And so this is not, again, a full picture for every patient, but when you see these findings, you should think of bilateral left-sidedness or left isomerism. And this is what interruption of the inferior vena cava with azygos continuation looks like by echocardiography. It is often something we can frequently pick up on fetal echocardiography, because you will see next to the spine, not only the aorta with pulsatile flow going down towards the toes, but you will see another vessel aligned with it with flow going in the opposite direction, a retroperitoneal vessel, and that is the azygos making its way up to one of the vena cava. So you can see that here in this picture, as well as in this subxiphoid view where you see these two vessels side by side with the flow going in the opposite directions. Ipsilateral pulmonary veins is one of the most challenging diagnoses for us to make by echocardiography. It can be hard because often these patients have almost a common atrium, so it can often be difficult to see where the atrial septum is and exactly where the pulmonary veins are coming in. But in this instance, you can see the right pulmonary veins coming into the right side and the left pulmonary veins coming into the left side. You can see it quite nicely in this particular image. And then again, I mentioned that if you have interruption of the inferior vena cava, the hepatic veins will drain directly into the atrium on their own. Here you see 4 pulmonary veins coming into this right-sided atrium. As this sweeps back, you'll see them again right there. And in this suprasternal view, there are actually many things to see, but you'll see that there are bilateral superior vena cava here. You'll even see that there is total anomalous pulmonary venous connection seen here. But what you see here are hepatic veins. Some hepatic veins here are draining to the right-sided atrium, and some hepatic veins here are draining to the left-sided atrium. And when you think about this problem and think about single ventricle surgical strategy, it may be hard to bring all of these veins into a Fontan baffle. And these are some typical findings of a patient with left isomerism. In the subxiphoid view, you see a common AV canal, slightly unbalanced to the right. You see an aorta and a pulmonary artery, which are clearly arising from the right ventricle. And so this is AV septal defect with double outlet right ventricle, big ostium primum ASD. And so this is a common finding. This patient also has bilateral superior vena cava, which you can see right here and here, and also has bilateral left pulmonary arteries. And when you look with color, you see that, as we often see, that there's mild pulmonary stenosis from conal septal malalignment in this double outlet right ventricle. And 3D echo has certainly enhanced our understanding of many things, including heterotaxy and isomerism. Here, when you look up from the ventricle, you see a common AV valve opening to both ventricles with a superior and inferior bridging leaflet. And it is very clear that the aorta and pulmonary artery are both arising entirely from the right ventricle in this patient with the conal septum in between. And you can see that in this clip as well. Some of these patients will have actually small aorta and coarctation. This is a patient with unbalanced AV septal defect with left isomerism. where the AV valve is emptying almost entirely into the right ventricle. But take note of the fact that the coronary sinus is very large in this patient. It's really quite dilated. And that is because this patient has interruption of the inferior vena cava with azygos continuation to the left superior vena cava. So all that blood is going from the lower half of the body is going through the coronary sinus into the atrium, and that's why that is so enlarged. And just to mention that complete heart block, which I alluded to earlier, often patients who have heterotaxy, left isomerism, with complete heart block, you can see this person has an AV canal defect, will also have non-compaction of both ventricles. And even if you pace these patients very early, essentially from birth, what often will happen is because of the non-compaction, they will develop a type of cardiomyopathy, which ultimately results in demise or need for heart transplant. You can see how in this patient early on, ventricular function was relatively okay, but over time developed severe RV dysfunction over time. Transition to right isomerism, or the Van Prague term, is asplenia. And again, now think the opposite. So this is bilateral right-sidedness. So there are frequently bilateral right atrial appendages. Bilateral superior vena cava are common, but now the left superior vena cava will come directly to the left atrium because there's no coronary sinus. And we use the term bilateral inferior vena cava because the patient typically will have an inferior vena cava coming to the right atrium, but they will have hepatic veins that separately come to the left atrium. Again, absence or unroofed coronary sinus. And now, because the patient doesn't have a left atrium, the pulmonary veins don't connect back to the heart because they can't connect back to a left atrium. And so many of these patients will have total anomalous pulmonary venous connection, extracardiac type. They will typically have bilaterally trilobed lungs with eparterial bronchi. Usually they'll have an absent spleen, but not always. Again, not a consistent finding. And they will have unbalanced AV septal defect, right dominant, almost, I don't want to use this term because it's obviously been controversial, but almost right single ventricle, along with ventricular arterial alignment abnormalities, such as double outlet right ventricle, the aorta arising from the right ventricle with pulmonary atresia. And very frequently, these patients have pulmonary outflow tract obstruction or pulmonary atresia. And that same image I showed you earlier when demonstrating left isomerism, again, in the normal heart, you see the SVC and IVC coming into the right atrium. You see the pulmonary veins coming into the left atrium. And now with bilateral right-sidedness, you'll have bilateral superior vena cava, but now the left superior vena cava comes directly to the roof of the left atrium. The hepatic veins can drain separately from the inferior vena cava, which does connect to the right atrium in this case, and you'll have total anomalous pulmonary venous connection. And so this is sort of just a reminder of many of the findings you can see on right isomerism. Here are just two examples of total anomalous pulmonary venous connection types you can have. This is total veins to a vertical vein to the innominate vein that then drains into the superior vena cava, as you see here. So here's the vertical vein coming in, superior vena cava here, back down to the pulmonary venous confluence. And here you see infracardiac total anomalous pulmonary venous connection, where you see the pulmonary veins coming in along the vertical line of this vertical vein here. Common intracardiac defects in right isomerism, often you see only one ventricular chamber giving rise to both great arteries. So here you see dextrocardia, common AV canal or common AV septal defect, a tiny pulmonary artery and a large aorta. And when we, go back for a second. I don't know if I can get that to work. I'll try. Nope, I can't get it to work. But what you'll see on this image is that you have a single pumping chamber with a common AV valve, right atrium, left atrium, and single, here we go, right ventricle. So it's extremely unbalanced AV septal defect. And here again is the essence of right isomerism in a single sweep. So if we stop this image, we'll see that we have unbalanced AV septal defect, which you see a common AV valve here. You'll see that the aorta arises from the right ventricle here, right there. Now you'll see that there's pulmonary atresia. Here's the ductus arteriosus giving rise to the pulmonary arteries. There's no main pulmonary artery segment. And if you sweep back, you see that there is a pulmonary venous confluence, and this patient has total anomalous pulmonary venous connection of the supracardiac type. So in one sweep, we were able to make essentially the entire diagnosis of this patient. And this is just really a telling, it's actually one of my favorite clips of echo that I have, because it really tells the story of mirror image. Here you have bilateral superior vena cava, you have two right pulmonary arteries, you have total anomalous pulmonary venous connection with the veins coming down to a vertical vein, such that if you really just draw a line here, you can see the mirror image nature of this disease in this patient with right isomerism. Patients with heterotaxy can have malrotation, and it depends on the study you look at, but it can happen in both subtypes. And it occurs when there's absence of the fixation of the mesentery at the two widely separated points, the ligament of Treitz and the cecum. And it puts these patients at risk for midgut volvulus. Not all forms of malrotation put them at that risk, but it is important to note that they can have that. And some recommend prophylactic LADS procedure. There are case reports of life-threatening volvulus, but it's not common. But there's also reports of small bowel obstruction after LADS procedures are done. And so this area of whether to do a prophylactic LADS procedure in these patients remains somewhat controversial. So most patients with heterotaxy or isomerism will go down the single ventricle pathway. They are a higher risk group than other single ventricle patients because of the concern about common AV valve regurgitation, the fact that they often have bilateral superior vena cava. They will often have dextrocardia, which can make it challenging with regard to a Fontan baffle, for example. They seem to be at risk for the earlier development of pulmonary arteriovenous malformations after they have the second stage, the Glenn procedure. It is quite challenging to determine where to place the Fontan baffle in these patients. So to demonstrate this challenge, I'm going to leave you with a case. This was a patient of mine, a 10-year-old with left isomerism, unbalanced AV septal defect, with a hypoplastic left heart syndrome type because he had aortic outflow tract obstruction. So he had initially undergone a Norwood procedure and then a Glenn. He had bilateral superior vena cava. He had interruption of the inferior vena cava with azygos continuation to a left superior vena cava. In fact, that clip I showed you of the patient with the very dilated left superior vena cava, that was him. And so because we didn't know better in the early days, we made a normal Fontan baffle from his right-sided hepatic veins, which remain draining into the right atrium, to the right pulmonary artery, so the classic Fontan extracardiac baffle. We did this at the usual time. However, he had already developed some pulmonary arteriovenous malformations prior to that procedure. So then he developed left-sided pulmonary arteriovenous malformations and developed cyanosis. And that's because all of the hepatic blood, the hepatic venous blood, was now going to his right lung. And because he had interruption of his inferior vena cava to the LSVC, all of the blood that was going to his left pulmonary artery was coming from that azygos, and he wasn't getting any hepatic venous blood from into his left pulmonary artery. So he underwent an analysis to determine a new ideal Fontan baffle placement for him for to try to get hepatic blood flow to both lungs. And what we essentially decided to do was take down his right-sided Fontan baffle and connect his hepatic veins directly to the azygos, which was going to the left superior vena cava. And you can see this very unusual looking baffle. Here you see that image I showed you earlier where the azygos and the aorta align with each other, but now you see something coming off at a right angle, which is his Fontan baffle, which is connecting his azygos to his hepatic veins. And if you look at this subcostal view, here are his hepatic veins down here, and you can see the baffle taking this very acute angle to go over to his azygos vein. So we patted ourselves on the back. Within 2 weeks, his oxygen saturation improved, and we were very pleased with ourselves. But unfortunately, a month later, he had desaturation again. So now we had limited hepatic blood flow to his right pulmonary artery. So now all the hepatic venous blood was going up into his azygos, and it was almost all going into his left pulmonary artery, and he developed AVMs in his right lung. So then we realized that because he had bilateral superior vena cava and had bilateral bidirectional glens, his central pulmonary artery had gotten quite small, so that there was very little cross circulation between the branch pulmonary arteries. And so we decided to place a stent in his central PA to promote that flow. And here is that stent placed between both vena cava, and the right-sided pulmonary AVMs went away after we did this procedure. And he's now 18 and doing quite well. And they have not recurred. So in conclusion, with echocardiography of heterotaxy or isomerism, you need to take a systemic approach and know your subtypes. And when you know your subtypes, you can look for the common associations that are dependents on those subtypes. Beware of anomalies you may not be able to easily identify, such as ipsilateral pulmonary veins. And you also, in any patient who you suspect is having heterotaxy or isomerism, have to extend beyond the heart and look for such things as malrotation with upper GI series, as well as splenic function abnormalities, because many of these patients will need to be on prophylactic antibiotics to protect them against infection. Thank you very much for your time.
Thank you, Meryl. Sorry for a delay today.
Oh, Sasha.
Sometimes we do surgery. I don't know.
Yes, yes, understood, completely understood.
And sorry with Norman, because today we changed the platform, so we are now in a new, brandly new platform, so some problem comes.
I mean, if this was baseball, I would have had several curveballs thrown at me. Good morning, Meryl. Hello, Ellie. I tried to get hold of you. But number one, your daylight saving time and hours are different. So I started attending the meeting at 10 a.m. So I've been on here for actually 2 hours already looking at this data. And then I couldn't get hold of Elio's telephone number, so to call him to tell him that I was not visible. So I've been here, Meryl, and I've heard your entire talk. And let's get down to business.
Okay.
Meryl, it was excellent. And I am sure that you and I have almost no conflicts in terms of what we think about this condition.
That's good to hear.
On the other hand, I can feel the hot wind of Professor Anderson breathing on my neck. So I will have to try and develop this ecumenism, this ability that we can all talk to each other rather than we divide each other. And I think that what we have to think about from the genetics point of view, which is so beautifully pointed out by an article in circulation edited by Dr. Tal Cava and Stephen Sanders, on what happens at the nodal pit in the three layered embryo early on. And that at the nodal pit, there is on the left-hand side a cilial structure, which when it wiggles tells the cells, listen, you must go to the left side. And we have to really understand, in fact, that this is not a chance condition, that
Correct.
this is a genetic condition,
Mhm.
and the genetics are varied. And as you said, a primary ciliary dyskinesia, which is usually called situs inversus, if I might use this term, which Professor Anderson would call mirror image dextrocardia, is
Right.
again this issue. And primary ciliary dyskinesia is very full of isomeric conditions. So,
Correct.
and there's at least 14 genes now that are involved in this. So the one thing that we can say is that the genetics of this condition are really what determines what's going on. And it determines very early on in the nodal pit. And if you have bilateral cilia on both sides of the node, you get double left-sidedness. And if you have absence, you get double right-sidedness. And I've used the term that I think is much better in deciding this condition, and that's this issue of what do we call this issue? And I like to think of this because of something that's very important about what you said, is that if you have in your mind, as an echocardiographer, the issues of that distinguish left from right isomerism, and as they fall into place in your mind, you then develop much better aspect of looking at everything to see what the real diagnosis is of left isomerism or right isomerism. I don't like to call it polysplenia or asplenia because, as you mentioned and has shown recently in the brilliant paper of Lim, I think her name is, from Toronto, which I can recommend to all readers and listeners to this talk, are best understand that there is a violation of the sort of simple rules, so that you can have patients that have no spleen, that really have left isomerism, and you can have patients that have a spleen that have left isomerism, and
Correct.
multiple spleens that have it, so that there's a violation in about 25 to 30% of patients. And that also makes it very difficult because people that define left isomerism or polysplenia, as you would call it, by that are going to miss a number of the patients that are genetically and phenotypically of a different variety.
I totally agree. I think,
well.
I agree with you. I don't like the term asplenia and polysplenia either. I use them because they are used, and that's the original von Proggian terms. I would say that, to me, when you think about this disease, and if you think about bilateral left-sidedness, bilateral right-sidedness, that really is a much more helpful way to be able to image a patient and get an understanding of what's going on, because you're right, that is not the most consistent finding.
Absolutely. And
I agree.
I think, just hang on, I wanted to just clear up one point. When you talked about mirror imagery, you talked about, in fact, situs inversus, which actually, on the term of heterotaxy, which means other than the usual, situs inversus is a heterotaxy. But really, our term of heterotaxy is a shortening of viscero-atrial heterotaxy. And as you see from Maud Abbott, as early as that beautiful description that you showed, I have her book in my bookshelf behind me.
Yes, me too.
And I think that, that is the feature. And in fact, we know, well, atrial appendages may be very early on, but the bronchial relationships are pretty typical. And I think that the issue of bowel malrotation, be it as it may, is really quite almost universal, because the bowel herniates into the coelomic cavity, into the umbilical area, and develops there, and then at 12 weeks comes back in an orderly fashion, which brings the appendix into the right iliac fossa and the sigmoid colon into the left fossa, and the bowel is ordered. And in the isomeric systems, these are often violated. And I think that's something that we have to remember about. So I would reserve the term of the isomerisms, which I prefer to call bilateral left-sidedness and bilateral right-sidedness, because it doesn't get in the way of anybody else's classifications. But I think that, you know, I think you've done a wonderful job. It was really quite beautiful to see the images, and you've covered almost everything, with maybe perhaps one or two exceptions, which I think are important to realize, because this is a disease that goes on for life. And there's a wonderful paper by Dr. Van Praag and Baruch Ticho about the changes that occur outside the heart in isomerism. That is really well worth a read for any of the listeners here. And we know, for example, that psychiatric abnormalities are very common in this condition, and they are the major ones. Manic depressive psychosis, schizophrenia are a problem, and IQ is another problem in these children. So, you know, you are giving the patients, when you look at them, they are multi-system. I saw a patient 2 years ago who came with perfectly developed, a lady, so perfectly developed secondary sexual characteristics at 16 years of age, who hadn't menstruated yet. And her MRI showed an absent uterus. And bilateral bicornuate uterus is very common. Male infertility is very common because cilia are important and cilia don't work. So this is a very, very extensive thing, and the horseshoe kidneys and other issues are a problem. So you're not dealing with a simple thing that the heart will be a recognizing issue, but it is certainly important. I have only one other thing I want to say, and I apologize for taking your time, but we're in America in the process of an election. And on the one hand, we've got the conservatives, the Republicans, and on the other hand, we have the Democrats, who are liberal. And I think this is just the same for left and right isomerism, because right isomerism is a conservative condition. When you get things in right isomerism, it is by the book, whereas left isomerism is a liberal condition. And Dr. Stella Van Praag pointed out to me that the only abnormality may be a left superior vena cava coronary sinus. And I came across a patient who had biliary extrahepatic biliary atresia, and nothing else was abnormal except he had an interrupted inferior vena cava, and nobody had recognized that he was a left isomerism. So I'll just preach those two little things to add, if I may, to your wonderful presentation.
I think those are excellent points. I won't get into the politics, but I do think you're absolutely right that the right isomerism is much more consistent in its diagnosis, and that there's much more variability in bilateral left-sidedness, left isomerism, whatever you choose to call it. Sasha, you wanted to ask a question?
I have a lot of questions. I have a lot of people that wants to live in Italy in few days, as Meryl also, if the politics will be not good. But the question is more clinical. Can you, because we have people from around the world, and Norman and we are used to make a perfect, trying to keep a perfect classification of this very complex disease. The people is asking, can you classify what is the worst type of anomaly? And because when the people knows that is a right isomerism with this disease, with this, and so they can have this in mind also for counseling, for ICU stay and other things. Thank you.
Absolutely. So right isomerism tends, or right, whatever you want to call it, right isomerism tends to be more severe than left isomerism. Because often those patients will have functional single ventricle. They will often have, this is one of the important findings, they'll often have either severe pulmonary stenosis or pulmonary atresia and total anomalous pulmonary venous connection. And when you have those two things together, no inflow into the pulmonary arteries and no outflow from the pulmonary arteries, the pulmonary vascular bed is often very abnormal. And so even if you try to put a BT shunt in and do a total vein repair in those patients, often they will not survive. And if you look at any of the studies that have come out in the last 2 decades, a study I did about 10 years ago, and then some of the work from Toronto that Norman was referring to, if you look, that prenatal diagnosis does not impact outcome of this disorder because of the complexity of the heart disease. And so even though we can make a difference in many structural heart disease abnormalities because we know it's coming and we can sort of treat it immediately afterwards, when you have this type of severity of heart disease, particularly pulmonary atresia, total anomalous pulmonary venous connection with single ventricle, that no matter what you do in those situations, the outcome is usually very, very poor. The two other very serious, the other two forms of this disease that I have very serious sort of discussions about poor prognosis with families are when you have left isomerism with congenital complete heart block, again, because many of those patients will have abnormalities of the myocardium that are quite profound and can lead to long-term ventricular dysfunction. There's a paper by Wayne Turetsky not too long ago which shows some improvement in survival, but it is still a very, very high mortality rate, no matter whether you're aggressive with a pacemaker and surgery and things like that. Again, because I think there's a developmental abnormality of the myocardium in those patients. And finally, patients
Which
with
ones
biliary
are you talking
atresia.
about, Meryl?
I'm sorry?
Are you talking about left or right isomerism?
That's left isomerism.
Sure.
That's in left isomerism.
Yeah.
And then, so I was saying in right isomerism tends to be more severe, Norman, but I was saying the two cases in left isomerism that carry a poor prognosis are when you have congenital complete heart block and when you have biliary atresia. You know, when you have biliary atresia with complex congenital heart disease, you know, just adding the complexity of having to do a Kasai, possibly a liver transplant with potentially single ventricle patient, all of those things carry poor prognosis.
Sure. I agree with you. I think that also it depends on when you start looking at this. If you look at the fetal examples, for example, when there's spongy myocardium in left isomerism, usually associated with heart block, there is a huge fetal loss. And the fetal loss, I think, in left isomerism is worse than right isomerism.
Yep, absolutely.
There's another point to ponder. Again, my colleague Julian Hoffman, who passed away this year, had suggested that perhaps there's a change in coronary vascular resistance when you don't have a coronary sinus. And Professor Anderson has pointed out that in right isomerism, there is never been a coronary sinus reported. So if you don't find a coronary sinus in a patient, when you're dealing with heterotaxy, as I would call the broad term, you have to start thinking along the lines of right isomerism. And one of the things that determines myocardial flow is the coronary vascular resistance. If there's an increase in coronary vascular resistance, then the perfusion of the myocardium is going to be compromised, and that can lead to poorer function. So I think that's a very important issue in terms of looking at what happens to the myocardium. And we obviously don't understand this, and nobody's ever really measured coronary vascular resistance, but the coronaries drain in the right isomerism by means of the Bayesian vessels to eventually to the right atrium. I want to make one other quick point, which is important, Meryl, and that's in terms of looking at right isomerism, and you've had this problem, I'm sure, yourself, that the inferior vena cava is often juxtaposed to the aorta, and the inferior vena cava is on the other side. So let's assume that we're just looking at where the cava and the atriums are. The atriums are on the right side and the cava on the left side. If you have to do a Fontan procedure, that's an extra problem for the surgeon, and one which, as an echocardiographer, you have to pay particular attention to, because if you miss that, the surgeon will be very angry with you because he goes into the abdomen and he can't find where the inferior cava is coming from, and it's a much more extensive and long baffle in order to bring the cava into what will become the appropriate atrium.
Right, and often the hepatic veins drain separately as well.
Correct.
So the point is, by the echo, Meryl, do you have some special advice for the evaluation of the, it means the stenosis of the pulmonary vein in isomerism? There is some, something that happens only in isomerism, or we can generalize is always the same?
Right, pulmonary vein stenosis can be an entirely different disease. So what we typically see with isomerism, with ipsilateral pulmonary veins, I don't think that they are particularly vulnerable to stenosis of the veins that I'm aware of. Norman may have other suggestions about that. What happens with right isomerism is when you have total anomalous pulmonary venous connection, particularly when you have pulmonary atresia, the pulmonary veins tend to be very small. The confluence is small, the pulmonary veins are small. And so when you try to connect the pulmonary veins back to the atrium, you often wind up with significant stenosis, either at the confluence or in the individual branch pulmonary veins, because they haven't had flow in utero because there was no antegrade flow into the pulmonary arteries. And so they've only had some ductal flow. And so you wind up with diffuse pulmonary venous disease on that side. And that is, in fact, likely the cause of the demise in many of those patients.
There is
you're 100% there, Meryl. The pulmonary veins are abnormal. It's not that there's no pulmonary arterial flow in utero, there's just some.
Right.
But it's much smaller, and
correct.
Those veins are going to be obstructed. And also in obstructed pulmonary veins, without isomerism, the issue of pulmonary venitis as an issue has become a problem as well. So I don't actually know what the cause of it is, but the number of patients that don't have a pulmonary venous obstruction with right isomerism can be counted on the fingers of a mutilated hand. And so, that's the problem that we face with right isomerism, is that whatever is causing the venitis, there's nothing we can do about it. And as you know, those patients are a nightmare to manage because nothing seems to work in them. You can do sutureless techniques, you can put in steroids, you can radiate them, you can do all sorts of things, and nothing seems to help. And it's an unfortunate and unsuffering death.
Yes.
Yes. So we'll go with the last question, so we will leave Meryl. The question is, would crisscross heart at the level of visceral atrial connection fall under situs ambiguous?
Say that again, crisscross.
Crisscross heart at the level of visceral atrial connection fall under situs ambiguous? This is a big question.
Yeah, I'm not. Are they asking if they see the systemic veins crossing over? My understanding of that, and Norman, you can add. My understanding is that does happen in heterotaxy. It's a very unusual finding, but that does happen. And what Paul Weinberg used to teach me was that if you saw the vein crossing over, that was a suggestion that the patient has heterotaxy syndrome.
Dr. Bob Van Meerop, Bob Anderson would always call him my very good friend. He's not a very good friend of mine, but I have met him. But he wrote very early in the 1970s in a volume on isomerisms, he called it heterotaxy in those days, that the inferior vena cava and aorta are juxtaposed in over 95% of patients. And if you mean that as a crisscross, that's very important. And I think that you do see that. I see it and look for it all the time. And of course, as you're doing your subcostal scan, and as we both being echocardiographers, you lay your probe down in the coronal plane and you start looking in the abdomen, and you look, I even look for the gallbladder, because I think finding a no gallbladder is already a bad news for the patient. So look for the gallbladder, look where the stomach is. And I would
Where the liver
say
is.
that my examination as a clinician begins by looking at the x-ray. I would say that anybody that goes to the bedside without going to look at the chest x-ray first is committing an error on themselves. So look and see where everything is, where the heart is, you feel much better about it. Look for the lobation, look for the bronchial pattern, look for edema, all these things. Look for where the liver is vis-a-vis the heart and where the apex is pointing. And then put the probe down and now start looking for the things that you couldn't see, like where the inferior vena cava is lying and where its relationship is to the aorta. And so I always teach, when the aorta and the inferior vena cava are on the same side of the spine, if the front vessel is the cava and the back vessel is the aorta, that is right isomerism. And if the front vessel is the aorta and the back vessel is a vein, that is left isomerism. And that's something that helps you straight away start categorizing these things as to what you're dealing with.
Excellent.
So Meryl, thank you very much. You promise us that we continue with you. Yes?
Sure. Yes, of course.
We will, people
We'll
is...
figure out some topics. Maybe some of the audience could suggest some topics. I'd be happy.
Yes, we will ask to them in the email, and we will try to keep you informed. But of course, we will go with transposition, 100%. No chance. So thanks again. Sorry for today, it was a bit late. We will keep in touch. Thanks to all the people, because today, Meryl, I don't know if you are able to look to chat, but we have people from all over the world.
I was going to say, there are people from all over the world. It's so exciting to see that. It was really amazing to see where everybody came from. So thank you so much for listening at whatever hour of the day it is for you. Thank you so much, and stay safe.
Thank you, Meryl.
Yes, thank you.
Great job.
Thank you very much.
Bye. Goodbye, Elio.
Bye, Norman.
Bye, Norman. Bye, Mary.
Send me your phone number, Elio. Hey, Sasha. Sasha, where's your moustache?
Coming soon.